stream. It has started now. Yeah, Dr. Deepak, you can start the proceedings. We are live now.
Yeah, good evening, everybody, and it's a pleasure to have you on board for yet another exciting session of organized by phacotraining.org. Last time we had a contest, about my biggest mistakes, and now the judges themselves are coming forward to showcase their big mistakes here. So actually, the point is we learn more from our complications than the regular cases. So there's the whole idea of trying to discuss these complications, and every surgeon is bound to have complications. If a surgeon says he doesn't have complications, then we have to be quite sure that whether he's operating or not. No, it's like that. So we learn more from our mistakes than from our so-called good cases. So the whole theme of the webinar is to try to showcase our big mistakes and then try to analyze why they happened, and we'll have the opinions of the other panelists here. So that's the idea here. And I'm very happy to have on board, apart from Sourabh and me, Dr. Neto from Brazil, Dr. Adrian, and our own Dr. Sunil. So they are our core group members of phacotraining.org, and it's a pleasure to have you on board here. And without much ado, I think we'll start the session. Saurabh, back to you.
Yeah, I think as Deepak rightly said, I'm all excited to show my complication and see all the experienced panelists, because we know that, they have done thousands of surgeries, and, the way they approach a particular complication is something we will learn from. And I think it is also good to see that experienced surgeons also do have some complications, that might, please it's like a pleasing thing to hear. But I think a lot to learn from all the panelists, and we are all looking forward to it. And the opening, what we say, player will be Dr. Neto, and he will be presenting his exciting case. And over to you, Dr. Neto, and you can share your first video.
Thank you, Sourabh, and wise words of Dr. Deepak that we surely will learn more from our mistakes and then from our successful cases. And I would like to add that a good surgeon learns from his mistakes, but an excellent or outstanding surgeon learns from other mistakes. So I think this webinar will be a very good occasion for all of us to learn and be better surgeons. It's a wonderful meeting that we will have now, and I really thank you both for the initiative, wonderful initiative. And I think your enterprise, the phacotraining.org.in, is an excellent way for every surgeon, not only beginner surgeons or young ones, but all of us to learn with each other. So I congratulate you for that. Can I share my screen, Sura?
Yes, sir. Yes.
Okay. So this is a 32-year, sorry. Let's start again. This is a very young patient, a 32-year-old young patient with a uveitic cataract and posterior synechia and fibrotic pupil. And you see the mistake I make and why I brought this case. So I start doing synechiolisis and then a pupillary fibrosis peeling. I'm showing all this because this is important to see how all the workout we must do in these cases. And then at the end, we do a very silly mistake that can compromise the result, the outcome. So I use a pupil expansion device, in this case, the BIIG. These cases must be very well planned. They are cases where you must have all the perfect preparation for a very good outcome. It's a very soft cataract, so only simple aspiration with the coaxial IA was enough to deal with the cataract. And now I'm implanting a hydrophobic 3-piece IOL, and I'm completely relaxed at this time because the most difficult part of the surgery is gone. But look now what I did. The chopper slips and causes a PCR. And surely this was due to lack of attention. And so I think it's not a catastrophic mistake per se, but in a case like this, with a young patient, a uveitic cataract, this can completely compromise the long-term result of the surgery. So I dial the trailing haptic into the sulcus, and then I retrieved the first haptic which was in the bag, was already in the bag, into the sulcus and positioned. So as vitreous has prolapse, it's necessary to do an anterior vitrectomy, and I do via an anterior way. I think this is one point of discussion, and to clean the vitreous and allow for a better centration and positioning of the IOL. So after this initial vitrectomy, anterior vitrectomy, I position and center the IOL and make sure that it is both haptics are on the sulcus. So I do a final anterior vitrectomy because some pigment and some bleeding has gone into the anterior vitreous, and I clean it up along with the OVD that has gone posteriorly. And after that, this is a critical step. I do a IOL optic capturing into the heraxis. It is not very easy to see here, but I stress that this is a key point in dealing with these cases. I'll discuss that later. So I wash out all the OVD. The pupil has come a little disformed by all the maneuvers, but it's very functional and small, and it's okay. So incisions, hydration follow. And now an important thing, it is to assess if there is still some vitreous there in the anterior chamber, and no, there is not. So we can close the incisions and final medications are done. So the case ends up well, but I think we have some discussion points here that I would like to discuss with you. Oh. I'm not being able to stop sharing. Okay.
Okay, a great case. I think, yeah, Deepak, you would like to add few points?
I think it was a wonderful case, wonderfully managed well, and just highlights, the most common, timing of any complication which happens, it happens whenever you think that the hardest part of the case is over. It has happened any number of times. You think nucleus management is tough in a tough case, and you do it, and during cortex extraction or during IOL implantation, this happens. It is purely because not of lack of skill, but lack of attention or lack of concentration of that. To highlight the point that, you can't take anything for granted. The message from this case would be, you can't take anything for granted, even including the last step of the surgery. He was in last step of surgery, perfectly performed surgery. I think it's just as he aptly said, it was just a momentary lack of attention or concentration that causes this, because I think it just slips and there's no space. It just went and hit. But having done that, and then actually we wake up. Once we have a complication, then our concentration becomes fully on there. And he managed superb. There's absolutely no doubt. He did manage very well. Thank you, Neto, for sharing this.
Dr. Neto, one just question, like because of your experience, you could rotate that IOL without pupil expander. But would you recommend putting maybe iris hook so that you can visualize the position of the IOL in a better way?
Yes, I think probably that Deepak has beautifully stressed out the most important um, message of the case is attention until the end. Do not take things for granted in surgery. That was a lack of attention was the cause of mistake. May, yes, I think you're right, Sourabh. Maybe iris hooks uh, prior IOL implantation would certainly avoid that because I would be seeing when I would see the chopper slip out of the haptic, and this would not happen. It was a small pupil, so when it happened, I didn't realize. I realized only when I was retrieving, and maybe iris hooks after that would help IOL positioning. That's I think it's arguably the best choice. So maybe I should have done that.
And another thing, like what kind of OVD do you use in case like this happens that you are putting a IOL in and there is a rupture and you want to now, reposition the IOL? What is your choice of OVD? Because we have either methyl cellulose, we have viscoat, or we have hyaluronate. So how
Yeah.
do you choose it?
Yes, due to my kind of work, I'm restricted to HPMC, but surely a better um, OVD would be best for this case. I usually avoid using when I have vitreous prolapse. I avoid, especially after doing the vitrectomy, using too much of this, so because it's very difficult to retrieve it from the posterior, uh, from the vitreous cavity. The OVD I did, but I would use a dispersive OVD to tamponate the area, but in this case it was very big. So I only use it OVD in the anterior chamber. In this situation, I think a cohesive OVD would be best because it would be more, it was only to maintain space in the anterior chamber, and it would be very much easier to remove a cohesive OVD in this situation.
Yeah, and Dr. Adrian or Dr. Sunil, you would like to add any point?
I would like to add something that you guys are titans of surgery and do thousands and thousands of surgeries, and you are very skilled of using a chopper or a Sinski hook to dial. I saw many of you just play with the 3-piece IOL and place it nicely into the bag or into the anterior chamber. I did couple of times this kind of catching the posterior capsule, and from that moment I said until I will be that skillful I will not use that again. So I tried to use the forceps, 25 gauge forceps, to take the leading haptic or the trailing haptic or whatever I have to manage, and place each and every one into the bag and make better to be safe than sorry, because I'm not that skillful to rotate the 3-piece IOL with the Sinski or with the choppers. So because I did that kind of posterior rents couple of times, and I said no more of that. So I always use the forceps to put the
I think that's a nice way of thinking. I think we'd like to see that video, like how you dial it inside. I think it will be good learning for all surgeons, because we want to have a safer technique for any procedure that way.
My second video will be like that.
Okay, great.
We'll see it today.
So we'll wait for that. Dr. Sunil, you would like to?
Yeah, as Dr. Deepak already said, no, it's not over till it's over. So whenever, the tough part is over, the adrenaline comes down. And I think we work best with adrenaline in our system and that's when we perform best. And when it comes down, that's when, things make the adrenaline come back again. The one
Yeah.
point I would have done in this case, I don't use, BHEX and Gupta ring that often. And this pupil is already deformed. What if we had already started with the iris hooks in the first place? You get much more exposure. And, with the other, of course, you're all are skilled to go ahead with this, but the iris hooks, at least for the, because a lot of people are watching us, at least for the more inexperienced surgeons, iris hooks, they work on any pupil, they give you a lot of exposure so you can see everything. And even you're dialing up the lens, or you're putting the lens into the sulcus, you can watch everything very, very clearly once you have hooks in there.
Yeah, perfect. And Dr.
Dr.
Neto, you are
Neto.
explaining about the optic capture. So can you just let us know?
Oh, yes, I would like to stress that this is another lesson I would like to convey from this case. The perfect 5 to 5.5 millimeter rexus is an insurance. Optic capture is important to ensure IOL long-term positioning and diminish sulcus placement complications such as iritis, pigment dispersion, and IOL dislocation. So this is an important mindset I have during my surgeries. I really strive to make a perfect rexus every single case, because if anything happens to the posterior capsule, I have a second option, which is a sulcus placed IOL with an optic capture. So I have a near best solution when this happens. And the optic capture, in this case, unfortunately, the visualization was impossible because the pupil was much smaller than the rexus. So, but as we are used to do these things without seeing, we can feel when you tap the border, the IOL border down, and the rexus margin captures it. You can really feel it with the chopper. But maybe for managing this case, I think Sunil is right. Iris hooks would provide a much better visualization. I opted for the BIIG because it's very unobtrusive, and as it does not lift the pupil margin, it's very much easier to work with the to do surgical maneuvers, as it was a much more easier or much more like your routine case than when using iris hooks. Sometimes iris hooks interfere with the palpebral aperture with the eye speculum, and you have some difficulty about that. And as the BIIG has a limited but sufficient aperture, it does not hurt the iris diaphragm as much as when you use iris hooks to get a full exposure. I usually avoid that to be able to achieve a functional pupil, a more functional pupil afterwards. So that's why I favor BIIG or another pupil expansion device.
I think just to add on, Neto, the point of optic capture is so much more relevant, particularly in this case, because in uveitic eye, you don't want the sharp edges of the hydrophobic lens in the anywhere above the capsular margin. So it's much more relevant in this case, although it's always relevant when you have a PCD rupture. But this was a young patient with uveitis. So you just want the haptics in the sulcus, nothing else. The optic has to go back. And your point is well taken. I think the BIIG ring should have been removed after the lens is implanted. Did you remove it before the lens implantation?
I'm sorry, I missed your last phrase, Deepak.
The BIIG ring, when was it removed? Was it removed after IOL implantation or before IOL implantation?
No, before.
Yeah. If you had just put it aside until the lens was there, your visualization would be still better.
Yeah. With three-piece IOL, I think we need a little more space, or maybe it would interfere with the haptic going on. With single piece IOLs, I usually maintain the BHEX or other pupil expander, implant the IOL, do the aspirate the OVD behind the IOL, and then retrieve the pupil expansion device. But in three-piece IOLs, I prefer to retrieve the pupil expansion device first.
I had one case where I was using the hydrophilic IOL with the double haptic design, and the BHEX was there. And this was my first or second case using BHEX. And the trailing haptic actually, took that BHEX along with the lens into the bag. And then I had to actually cut the BHEX. It will be a nice complication, but unfortunately, I don't have its video. Maybe next time when I do it, I will definitely share that video. And I had to cut the BHEX and take it out. So I think Nito's point is very valid. When you are using a different kind of IOL, the haptic may get, entangled with the BHEX if you are not careful. Okay, can we move on to next video by Dr. Sunil? And I would request panelists, they can see the chat box and they can also answer questions there. So, yeah, Dr. Sunil, please share your video.
Okay. Where is it? Here. This was a referred patient by my colleague who had operated on him about 5 years ago, an uncomplicated SICS with an IOL. However, after 5 years, the IOL dislocated and the haptic was rubbing against the cornea. I couldn't dilate the pupil well, but I was sort of able to visualize the periphery of the bag. And I decided to take a decision on the surgical table as to what my plan would be. Now you can see from the picture that the haptic is rubbing against the cornea and the IOL is dislocated upwards. So since there was an incision superiorly, I decided to make a temporal incision, a valve incision. I put in some side port incisions as well. And my idea was first to dislocate this IOL with the help of iris hooks into the anterior chamber. And very easily I could dislocate this IOL into the anterior chamber. I was not very sure of the status of this IOL and hence I removed it, put in some more iris hooks to visualize the periphery. And I could see some calcified peripheral bag, and I thought probably there is a deficiency superiorly. So I put in another lens using that peripheral PC as a scaffold and making sure both the haptics were placed horizontally, completely away from the presumed superior deficiency of the bag. Then remove the iris hooks, removed the OVD, sent him home very happy with a vision of 6/9 with correction. He was followed up by the referring doctor and everything was well. Till 18 months later, he was referred back and to my horror, he presented similarly. Again, the IOL had dislocated and the haptic was rubbing against the cornea. And this time I realized my mistake. There was no PC. In fact, I had put the IOL, as my friend had done, on an anterior compact hyaloid fix. So I decided, yes, I have to go in. My first plan was to suture the same IOL onto the iris. So I dislocated into the anterior chamber and very carefully pushed the haptics against the iris so that it will drop into the sulcus. And the other haptic is not so easy, it had to be done manually. All was going well, little difficult maneuver, but managed it. I then captured the optic with the pupil and then I was planning to suture the haptics to the iris. I did one mistake here. I put in some pilocarpine thinking I would hook that optic properly, but instead of that, the lower edge of the optic went behind the pupil, and trying to retrieve that and bring it over the pupil, the upper optic also went below the pupil. And the pupil completely shut down on me. So it was back to the drawing board again, put in some OVD, and my good old iris hooks came to my rescue again. Again dislocated the IOL into the anterior chamber. And this time I had to go to plan B. That was putting in an iris clip lens. And this time I didn't go from the temporal side. I again very carefully dissected a tunnel superiorly, brought out this lens. Mind you, all the time I have kept the hyaloid face intact. There is no breach of the hyaloid face. Put in my iris clip lens into the chamber, positioned it, and I used a Clement forceps and a Sensky hook to enclavate it. Mind you, this is almost my first case of an iris clip retrofixed lens, so I was a bit nervous. However, it went off pretty well, thanks to the videos that I watched of Sourabh and Kiranjit. I was able to manage this procedure, making sure I enclavate it. And in fact, you can see the haptic coming through. And then I have done an iridectomy with my vitrector. You have to excuse the quality of the video. This is an old surgery. And I sutured the wound. Postoperatively, he did very well. His vision was 6/6 with a minimal cylinder. And he has maintained it almost now 1.5 years, 2 years or more. Thank you for watching.
Excellent case, I think. Dr. Deepak, you would like to?
Yeah, it's just wow. Okay, so you did wonderfully well. And the concept of a thickened anterior hyaloid, which you mistook for the calcified anterior capsule or posterior capsule, is a new thing. You know, we have never seen a thickened hyaloid which mimics the calcified anterior capsule like that. I thought it looked like anterior capsule which is calcified and the peripheral remnant, but I never thought that it is an anterior hyaloid itself, because unless it is not a capsule, there's no reason why I should dislocate again. You're right. Why you said that it dislocated? Because there was no capsular bag. It was totally an intracapsular sort of extraction which has happened earlier, and there's no support for it to stay there. But what was surprising for me, how did it manage for 18 months? It did manage well for 18 months. That was something which is amazing. But your thought process was extremely right. And I don't know why the inferior haptic slipped down. Can you just elaborate why did it happen? That the inferior optic edge, it just slipped down. And then before you could do the second instrument, the superior optic also slipped down.
Yes. I think this is a single pace, a rigid lens. Okay. And if you look, the inferior optic, it was not that very well caught actually by the pupil when I put in the pilocarpine. So probably the anterior chamber pressurized a little bit, and this one dipped down. And before I knew it, it just, shut down on me. And, then after that, I knew it's anyway, it is very difficult to suture a PMMA lens to the iris. So I did not want to try it again. I thought this was a better option.
Why did you not choose the three-piece PMMA lens? It was already there inside, right?
Yeah, this was already there. So I thought I don't have to open up. I can just suture it, and why make another incision? Because you are saying you are surprised that it dislocated after 18 months. Remember, my friend had put it 5 years ago, and it stayed there for 5 years before it dislocated. And that is why I thought there was a PC, because you don't expect, 5 years it was there must have been a PC. Maybe something else went wrong. Although you ask for trauma and all, most people don't give you a history. But, and that was the thinking process. But luckily, the iris clip lens also, it was, you could see me, I was actually pretty nervous at that step, because that's the first time I was actually doing it. And actually I'd seen Saurabh's video before that, and I had seen Kiranji's video, so it was okay. I could manage, but that was a really a lifesaver. He's a young person, so that was a lifesaver. And the important thing is, you have to have all these backup plans with you whenever you go into these complicated cases. So you can't just think you can.
I think a surgeon has to develop the habit of being instinctive in thinking. See,
Yes.
nothing is prepared. You have to be instinctive. At that moment, you will be thrown with so many surprises, and you have to gather in all your experience and from whatever you heard, your thought, and all those things, and then try to come with a plan. So that's what this case teaches us. Thank you.
Yeah. Dr. Neto, yeah.
Yes, I would like to stress that single piece PMM IOLs are very difficult to capture either in the pupil as in the capsule when you try, because the haptic optic junction is a little different. It's too, the outer side is too smooth. It doesn't have a notch or a place for the iris or the capsule to catch. So it's very often we have this problem. After the pupil constricts a little, it slips and you lose the capture. It happened to me a lot of times, as just like that. So nowadays, I really don't try to capture a single piece PMMA IOL in the iris, or even try to do iris suturing. I simply extract the IOL and prefer to use a 3-piece IOL to do this technique, because it's very difficult to do. The haptic design is different. It's not in my opinion, a suitable IOL to do iris fixation technique, and because of this problem. But you manage it wonderfully, exchanging the IOL and so. This kind of situation, mistakenly taking the anterior hyaloid for the posterior capsule, happened to me many times. And it's very difficult sometimes to differentiate, and sometimes we do mistakes like that.
This is just my thought process for any PMMA IOL which is decentered or subluxated. I generally opt for IOL exchange rather than trying to rotate and place it, because I feel that there is some reason behind that decentration, because generally it will decenter because of dialysis, which you will miss on table, because it's very difficult to look for the dialysis on table. Also like this, completely absent posterior capsule or even the anterior capsular support may not be actually adequate. So I think what I will do, what Dr. Sunil did in the episode, that I will do generally in the first episode, because with PMMA I don't take those chances. Sometimes with foldable, if you are really sure, with 3-piece foldable, if you are really sure about the bag and because sometimes it may happen because one haptic is in the sulcus, one haptic is in the bag. But with PMMA, my experience is that there is always some reason for its decentration, and it's usually the support is not there for re-rotation of the IOL. Of course, you have to manage it case wise. If you have good visualization of the entire periphery, then you may be better equipped in thinking about that. Okay, so should we move on?
Something to
Dr. Adrian.
My take-home message from this case was that regardless of how experienced you are, we have to always keep an eye on everything and just keep our attention very, very clear, because that anterior hyaloid really fooled me. I was seeing that as a anterior capsule also. So it's very, very important to not go with the prejudgment ideas in our head, and really, really focus and pay attention to details and make sure we understand exactly the structures inside the eye. And it's very, very difficult after you get experience and all that, because we tend to get into a mind of like a routine and do things like we did it 1,000 times and look for just one split second and make a judgment. And I think it's very, very important to understand that sometimes a little one extra second of attention will make the difference in judging a different way a case, which in this case was managed superbly with the iris clock IOL.
Yeah. Okay. So next case is by Dr. Adrian. So I'll be sharing, and
Thank you.
here is his case. Okay. Is it visible?
Next, today I will only show you
Make it full screen, Saurabh.
partial
Yeah.
video, since our video recording device had close to full memory and was not able to record the entire surgery. This is a posterior polar cataract, as you can see, that quickly got interesting. That's why I wanted to show it to you. As soon as I start doing the Phaco emulsification, the nucleus got a little bit rotated, and that's when the first mistake occurred. And I was doing a trench and trying to divide the nucleus. That was the fatal mistake that ruptured the posterior capsule, and as you will see in a second, the nucleus will start to sink towards the vitreous cavity, towards the retina. And I used two choppers to bring it up through that small capsular axis. Here is the first mistake, and bring it up through the capsular axis, and I was able to finish the Phaco emulsification holding the nucleus with chopper underneath. And doing the anterior vitrectomy, I inject the IOL in the sulcus place. This is the second mistake, and you will see in a second. See, that's the moment when the vitreous came into the anterior chamber, and right here you saw the vitreous coming out when I took out the Phaco probe. Put some viscoelastic and hydro dissect the nucleus. I didn't have anything left to lose, so was no point in not doing that. The capsule was already ruptured. So after anterior vitrectomy and insertion of IOL into the sulcus, place two trocars, infusion in the anterior chamber, and check the vitreous cavity. We had one small piece of cortex that was very easy to remove. Remove the trocars, put some myocol to constrict the pupil, and some triamcinolone at the end to check for any vitreous trend. Everything was clear, and that's the end of the case. Thank you very much for your attention, and I hope this video will help you in your practice also.
The third mistake was that taking out the Phaco probe without placing any viscoelastic into the anterior chamber invited the vitreous into that incision. So in this case, there were like a sequence of three mistakes, one after another.
Okay, just stop share. Okay.
Yeah, so first of all, the polar cataract, we all know that can be with posterior rent starting from the beginning. So any rotation of the nucleus, which I accidentally did, will engage that posterior capsule and rupture it. And of course, cracking the nucleus will add to that if it's not done in the same plane, which the nucleus was tilted a little bit, so actually that enlarged the posterior capsule already. So once
Dr. Adrian, one question. When there was a posterior capsule rent and you rotated or you pulled the nucleus out of the bag, you still continued to do Phaco at that moment. So there was no vitreous at that time in the antechamber?
There was vitreous, but I was using the viscoelastic cannula to like push it underneath the nucleus and let me finish the Phaco emulsification, and then I got to the vitro settings, vitro cutters. I took out the vitro cutter and finished the vitrectomy. And of course, I had to do a posterior vitrectomy also because I saw just one fragment of cortex sinking into the vitreous cavity. So I had to take that out also. Yeah.
Okay.
This was not on the video, but that was the sequence on the surgery table.
Yeah, Dr. Neto, you would approach this case anything different?
Well, I usually refrain to use the Phaco to get the nucleus when there is vitreous present. I'm afraid of tumbling down the nucleus into the vitreous cavity and also getting vitreous on the Phaco probe and causing vitreous fraction. But sometimes you can do it safely. It's something that you only at the time you can judge if it's safe enough to do this. The most important thing is to recognize the PCR right at the time it happens, so that you don't continue with any maneuver that can endanger the case or cause any complications after. But this is something that sometimes you can do, and you can finish a case even with a PCE, if a posterior capsular rent, if you can isolate the vitreous, and then you can safely aspirate whatever nucleus there is. It varies. The situation it has a great variation that you should or should not do. I usually stop the case and convert, and or try to break the nucleus into smaller pieces and retrieve it without anterior chamber pressure, so as to avoid pieces falling down into the vitreous cavity.
Yeah. Okay. Dr. Deepak?
Congratulations, Adrian. You had a good outcome with this case. You did manage very well. Few things. If you are used to using AC maintainer, it really helps in case of postipolar cataract to continue using that. Because one of the most important principles in managing postipolar cataract would be never to maintain the chamber. So if you're used to using an AC maintainer, why not continue until the entire surgery is done with? It helps in multiple ways. So actually you remove the this thing to introduce the chopper, and but if there is one indication for to continue using AC maintainer, if you're very used to it, it would be a case of postipolar cataract. And then you prolapse the nucleus out into the antechamber and then continued Phaco. Maybe I would have converted to SICS because in the case of an existing PC tear, if I have diagnosed, maybe I would have converted it. If the nucleus is very soft and if you're sure that the vitreous has not yet prolapsed out of the posterior capsule into the vicinity of the pupil, then the second option would be to use an IOL scaffold technique. Put a lens behind or in the surface of the iris. Because the nucleus is very soft, you can aspirate it in the antechamber. It's not going to be much of an issue. These are the two points from my side. Thank you so much.
That's a case of 3 years ago, when at that time I was trying to get rid of the using of that AC maintainer. So yeah, probably if I would have put the separate incision for the AC maintainer and use it straight up from the beginning to the end, probably the outcome will be without that PC rent. As you say, the continuing pressuring on the anterior chamber, it's very well maintained with that maintainer. So yeah, probably the PC rent will be avoided if we have continuous pressure, either with viscoelastic or the AC maintainer.
Thank you, Dr. Adrian. I think next video is Dr. Deepak's, so he can start sharing. And
Clear. Is my screen visible now? Just play. Okay. Is it all right?
yeah.
So this is one of my most nightmare cases. You can say this is probably one of my biggest mistakes. And
welcome to my big mistake. Well, it was a routine day at work. This is the third case of the list. About 2 years back, a 79-year-old lady, a really innocuous looking case, well-dilated pupil, rhexis is done, looks fine, hydro procedure is done. Nucleus rotation is done to ensure that there's no corticocapsular adhesions. Everything looks fine. Time to Phaco. Easy nucleus, easy to chop. It's consumed in a jiffy. The epinucleus is also removed. Now I was thinking, remove just this little bit of cortex and put in the lens and the case is done. I'm careful to engage the cortex and then put it to the center, and then I'm aspirating it. Meanwhile, I ask the next patient to be shifted. The cortex is taking unusually long to get aspirated. Hang on, is there something wrong? I retract the iris and see that the capsular margin is missing. With a great sense of hopelessness and helplessness, I realized that the capsular bag has been stripped along with the cortex. The zonular dehiscence was huge. I'm pushing the reflex switch, and as it always happens, it does not function well at the moment it is required to. Eventually, the cortex in the bag is disengaged from the port. At this moment, you know what I was feeling? I realized that I was feeling that I had dug myself a very deep, deep hole and was lost in the black hole. Okay, back to reality. How do I go about now? I inject OE to form the bag. I'm hoping that I can peel off the cortex, and I go in with my aspiration, but the cortex aspiration is extremely difficult. Capsular bag is wanting to come along with it. So I want to put in a CTR, but I'm not certain about the integrity of the rhexis. I retract the pupil and see the capsular edge, but not sure about being continuous. I take my chance, put in the CTR under the anticapsule. I thought the job was done. I was relieved momentarily. I thought the bag is well supported. I continue cortex extraction. Throughout, I am maintaining the chamber equilibrium quite well. At this moment, I see this suspicious area in the posterior capsule. Well, I realize now that my worst fear is now a fact. By the time I aspirated the cortex, a large PC tear was staring at me. I'm retracting the iris to see any capsular rhexis edge here. In this quadrant, I can see some area of the anticapsule, but again, not sure whether it is continuous. Well, the rhexis margin is continuous in the other side. At this moment, there is no vitreous prolapse. I push in triamcinolone acetate, confirming that. The tricot has gone behind the PC tear, but nothing is in front of it. I still go ahead and decide to perform a pars plana enterectomy. My thinking at that moment was that I could still manage to place an IOL in the sulcus, but if the vitreous prolapses later during the surgery or in the early post-op period, centration of the lens would be an issue. So here, I make a pars plana port and I'm performing minimal antivitrectomy. Once it's done, I create space under the iris with cohesive OVD. Inspect the anterocapsular margins once more. And then I'm implanting the multipiece lens. The lens is dialed in a plane which is above the anterocapsule, and I'm ensuring that the haptics are in the area where the anterocapsular integrity is maintained. One last time, I go in with my cutter behind the lens, remove the OVD, and the OVD in front is removed. Pilocarpine is used to construct the pupil. I switch the sclerotomy and the conjunctiva. Mentally, I was ready to perform IOL explantation and put an iris claw lens and had the lens decentered in the early post-op period. Post-op medicines are prescribed and we all prayed. So here is a third day picture. Not bad. I was happy. 1 week later, I dilated the pupil and was very pleased with this picture. The lens was quite well centered, taking into the account the trauma which we had during the surgery. Well, one thing I had to say. I said, wow, prayers do work. So let me rewind back and show my big mistakes because there are more than one. Number one, inability to achieve a perfect cortical cleaving hydrodissection. This was the starting point. Catching the bag along with the cortex. Too late to detect this massive bag detachment. The heat of the moment, trying to disengage manually, probably causing the nick in the anterocapsule, which then extended onto the posterior capsule. Inserting the CTR. Well, this was tricky. I'm not sure whether I could have done without it. But what I liked about myself in this situation, I hung in. I didn't give up. Thought of multiple options. I was very slow and patient. It took almost 80 minutes to complete the surgery. Technically, I thought choosing to perform pars plana antivitrectomy served me well. It helped me to prevent the extension of the posterior capsule tear, although it was quite big to begin with. And I was committed for IOL exchange if the need arises. To conclude,
this nightmare really haunts me. It continues to haunt me. This sight is really frightening for me. Thank you.
Thank you, Deepak. I think that site, I think everyone has seen that, site, and our heart had stopped on such occasions, I'm sure. But the way you managed this was really good. Just one question: when there was when you inserted the CTR, you were able to visualize the CCC margin when you are inserting the CTR?
I tried to fool myself, I guess, to be honest. I led myself to believing that, okay, there is still a continuity of edge because one part of my brain was telling, no, it could not be there because, people also has come down. But I tried to fool myself into believing that maybe it is still there, nothing is going to go wrong. And that was the, because there is no way I could remove the cortex now because the black was always coming back. There was no way I could have retained the bag. So that was I fooled myself into believing that maybe there is something like this is a little bit of tear is there, but it will still withstand. And that's the reason I fooled myself into believing and put it, because I did not find any way to, continue removing the cortex with the bag always folding into the, the aspiration port. Believe me, I was not absolutely certain that, I was sure that maybe there is somewhere a nick is there in the rexus margin.
Okay, and where is the CTR now?
It's in the sulcus, happy. It's in the just sitting in the sulcus.
And excellent. I think Dr. Neto, you'd like to, and Dr. Adrian, Dr. Sunil also.
Well, I think we all we all have been in this situation. It's horrible when you notice that it's the bag is coming out and say, no, that can't be that. And well, I think one thing I would like to say here is when you have some zonular compromise and you have cortex in that quadrant or in that area, it's most important to try to pull the cortex tangentially. So this is the best way to try to get this cortex with minimal zonular traction that will make the zonular compromise worse. But sometimes it's best to leave it there and as you did put a CTR and go on. But we have all been there, and sometimes it's difficult to notice at the time that you are bringing the bag together, especially when you are dealing with less than ideal pupil dilation. When you're working with smaller pupils, it's very easy to do that. And some patients have a generalized mild zonular compromise that doesn't give up any sign during for the patient examination at the sleep lamp, at the time when you're doing the capsular access. Only when you get the capsule, you catch the capsule with the IA probe and pull the zonule disengages, and you have a zonular dialysis, and it's a complete surprise. So some cases you just can't preview or be aware of that before you make that. Wonderful case, Deepak.
Thank you.
Yeah, actually, Deepak, as usual, always wonderful cases from you. But you see this quite often in very advanced cataracts, especially in very mature cataracts, when you go aggressively trying to pull out the cortex and the zonules can just come off. And but I wanted to ask Deepak one question. What didn't you think that you could put capsular hooks and pull back the bag and then try to do some aspiration instead of trying a CTR?
No, see, the thing was, the capsule rim was very thin and flimsy, and it was almost 180 degrees, or almost say maybe 45 to 60 degrees of dehiscence was there, and I was not able to localize the edge of the capsular margin at all for me to go and hook with a capsular hook. So it was just not, it was out of the picture because it was all wrinkled, folded. I could not identify anything. And that was the situation where that was not an option for me there.
Dr. Adrian?
That was a great outcome, and I gotta share you a not so lucky event that I experienced a couple of years back when one of my residents had the same problem, and until I said stop, he, instead of disengaging the bag from the aspiration tip, he took out the instruments, and I had a full bag on the instrument table. So that was a sight to see. So I had to start with the technique to fixate the IOL to the sclera then. But yeah, these sentences, they are very, very often, especially when the patients are coming very late and operate the cataracts in very, very late stages, like over 80, 85, 90 years old. We have to expect that the zonals, even if the slit lamp exam don't show any sign of zonal weakness, when you see a very, very old patient on a table, we must keep that in mind, that zonals are not that healthy anymore. But unfortunately, you can see this kind of zonal problems in younger patients nowadays. So really, this can catch us off guard. So
Yeah.
like Dr. Neto said, it's better to just make a habit into aspirating tangentially and slowly first cortex strands and just to test a little bit the zonals at first strokes of aspiration that will give us a hint into the healthy of that zonals.
Yeah, another trick that I use, like not for the cases where zonular weakness is there, where you have to be more careful, but this happened, I think, with good zonules, and that's where even beginners have this dialysis. So what I use, even I have shown in my video, is instead of pulling the cortex centrally, I pull it downwards, like towards the posterior capsule. I think this was shown to me by Dr. Abhay Vasauda sir, that instead of pulling the cortex centrally, you pull it posteriorly, so the capsule is away from your IA tip. I think that helps you in doing a very safe cortex aspiration, because the fluid is there in between the capsule and the cortex, so it cleaves the cortex away. And because the capsule, because of the fluid, it cannot bend down unless there is a significant zonular weakness. It always is pulled up. So I think that is best way to avoid these situations. This was shown to me by Dr. Vasauda sir. I think any surgeon who does very fast cortex aspiration can use this technique, and he will not have any zonular dialysis in his case.
I think one important point which I'd like to highlight is cortical cleaving hydrodissection importance has to be highlighted in this case, because I saw a fluid wave, I rotated the nucleus and confirmed that everything is fine, but the fluid wave had not separated the capsule and the cortex. In some of these patients, the capsule and the cortex are sticking so well together. The moment to catch the cortex, the capsule is already stuck into there.
Already.
So even you put down or forward, whatever movement you do, everything comes along with it. So the importance of highlight the cortical cleaving hydrodissection cannot be emphasized. That can be, the trick is the fluid wave has to be very slow. If it is a rapid fluid wave, posterior fluid wave is very rapid, then you have to be very certain that, it is not a cortical cleaving. It is just in between the epinucleus and the cortex. The fluid has gone in. That was the situation which happened here. The cortex was very firmly sticking onto the thing. The capsule.
Yeah, but I feel generally only if there is a zonular weakness, then only the cortex will, the capsule will come along with cortex. Otherwise, it should not.
Yeah, it was. That's what. But in zonular weakness only, you have to spend a little bit more extra time
on
to
the
do the cortical cleaving hydrodissection, because it was not anything unusual. And the last take-home message would be, because so many people are watching, you will not always be lucky, as I was in this case. So, you all always have to mentally be prepared to have an IOL exchange, either fix the same lens with an M&A technique or retrieve the lens. That should be fine.
Yeah, I think that's, I think having a backup plan, that's why I think there is an importance of learning how to use the iris claw or SFIOL, because it always saves you in such situations where you have dilemma whether whatever you are going to put in can cause problem later on. Okay, so I think Deepak, can I share my video now?
Sure.
Yeah. Okay. Just give me one moment.
Hello.
Okay, here is my video, and it's with the audio. So I am Dr. Sourabh Patwardhan from Nanda Deep Eye Hospital, PG Institute and Phaco Training Center, and in this video I'll be speaking about a case of subluxated lens, and I had some issues while handling the CTR. So this is a young patient, history of trauma, nystagmus is present, and there is subluxation, and patient has a very poor glow because of the density of the cataract. The central part is more dense, as you can see here, not allowing any red reflex from there. And the first mistake I committed here is that I decided to rely on the red reflex, which is very poor in this case, and particularly in the central region, and I did not stain the capsule, and I realized it the moment I started the capsular axis. Though I could faintly visualize the flap, but still I could not actually see the edge of the flap, and now I was struggling with visualization. So despite knowing that there was a poor red reflex, I did not stain the capsule. That was my first mistake. And then I decided to go ahead with the forceps, because in forceps you can grab and re-grab for lesser attempts and complete the rexis. That was my plan, and I thought that I have completed the rexis now. Again, this was mistake. Then I thought that I should confirm whether the capsule rexis is okay or not. So I decided to wash off the viscoelastic. I have used viscoat, so it's difficult to wash out, so you have to actually aspirate it. But the moment I started aspiration, I realized there was a free flap, or the tear of the capsule rexis which was there, which I could not visualize before. So now I have used hyaluronate over the capsular flap, which I could see very faintly, and then again I use the capsule rexis forceps to complete the rexis. So I think, despite knowing that I'm going to have trouble with visualization, I did not stain the capsule. That was a big mistake that I did. Of course, you can always cover it by washing off the viscoelastic and staining the capsule again. Because of the subluxation, you can see there is a temporal weakness of zonules. Luckily, it is not as extensive as I thought. So I thought that I will support this lens with CTR, and that should be more than enough. So I started inserting the CTR, but look at my left hand. I was not supporting the CTR, and obviously it is stretching over the capsule rexis, as you can see in the upper part of the video. And now, despite knowing that it is not going in the bag, just watch how it is looping around in the sulcus area. It's not going in. I decided to just let it go. I think, despite knowing that this was not the right place to leave it, I made this another mistake, and obviously the CTR is not in the bag. It has gone into sulcus, and because of the poor visualization of the capsule rexis margin, I am not very sure whether one end of it is inside the bag or not. But then now I realize that I have to go ahead with removal of the lens so that I can see better with red reflex. And again, another mistake I committed here is that despite having the subluxated area, I did not support it with capsular hooks, which I should have done. Luckily for me, the subluxation was not very severe and might have been slightly supported by the partly in the bag CTR, and I could remove the soft nucleus with just aspiration. And now this is the scenario. Now I can see the pear-shaped capsule rexis here, indicating that a part of the CTR was in the bag while part was lying in the sulcus. Now I have to get the CTR back from here. I cannot put another CTR because it is going to jump out again from the bag. So the clue was that notch of the pear-shaped rexis where the CTR will be going in the bag. So I lifted it from that side. This was a good maneuver, and I tried retrieving it out of the sulcus, and I should have continued rotating this CTR out of the bag. But another mistake that I committed over here is I tried to use another forceps but released the CTR. The forceps which was holding it up, I released it. Luckily, the CTR which came out went into the angle rather than into the sulcus. Otherwise, it would have been lost CTR into the sulcus. And now I could grab the eyelet and rotate the CTR out of the sulcus here. So I was lucky not to lose this CTR into the sulcus, but I think I made series of mistakes here which I should have avoided. Now for the second attempt of CTR, it is important. Now I am showing that I have to push the CTR down into the bag while I am pushing the CTR. So using both the hands is important. You can also use CTR injector, and then don't release it until you are sure that you are placing the CTR in the bag. So at the end, the result was good. I placed 3 PCIL supporting the haptic on the subluxated area, but I think I could have had complications because of the mistakes that I committed during the surgery. Thank you for watching. Okay, so that was my video. I think I was lucky to get out. I think I was lucky to have very limited subluxation and get out of the situation without having much issue. But I think I feel that in such case, sometimes the surgeons, though they know that what they are doing is wrong, either they know that what they are doing is wrong, still they go ahead with the procedure, thinking, feeling that just like Deepak said, it will go all right, whatever we are doing. Or the second thing can be that surgeons do not know what they are doing is wrong. So I think I was in the situation where I knew that I was doing something wrong, but still I went ahead. So I think that was my big mistake, and that should have been avoided in such cases, because it can go wrong and we could have unfavorable outcome. Yeah, Dr. Neto.
Yes, well, Sourabh, great case and wonderful management. I think on your behalf, I would say that most of the times when I have a subluxated lens, I avoid using trap and blue because of the risk of it going back into the vitreous and making the visualization situation much worse. So I think it was unforeseen, but you have some difficulty. But I'm sure I would not have used a dye in your situation either. I would try to make the rexes without dyeing the capsule. In these cases, I pay the utmost attention where I leave the flap when I release it to regrasp. That's the key, not to lose where you are and where the flap, the tear is going. So it's the only way to ensure that you do not miss it. I would like from the other panelists and the participants some insight when how to use a dye when you have a big zonular compromise, and avoid the dye, how to avoid the dye into going into the vitreous cavity, if someone has some technique or idea about it.
Yeah, what I do is that I push some viscoat in the area of subluxation, and then I stain the capsule. Here, I think, Dr. Neto, which OVD do you use in such cases? Do you prefer methyl cellulose? Because I think one mistake I did was that I injected viscoat, and viscoat doesn't allow the flap to stand up. So, when we are rotating the flap, if you cannot see the edge, it becomes very difficult. So, is it better to use HPMC than viscoat when you use it in subluxated case?
I think maybe it is, but there is a way when you can pull the flap up and you can visualize it better. But I really don't know if it would make any difference. But this is most important when you're doing without visualization. You do it like that. I'm from the time when we did not have sharp and blue.
That's the secret.
We
That's
had
the
to do
secret.
white cataracts without any dye. Sometimes we used retro illumination, but it was a very poor thing, and it didn't work. So I don't know. We old foxes that have have had this experience. We are we are used to that, to do this without dye. I mostly avoid using dye. It's some surgeons prefer to use triple blue in every case for better visualization. I don't think it's necessary, but this is a personal matter. But in this case, in particular, I think I would not have used it because you have some kind of visualization, and perhaps would be able to follow their axis and do not lose it.
Great. So,
But
yeah, Deepak, Dr. Sunil, can you keep your case ready? Because,
Sure.
yeah, Dr. Deepak, you want to?
yeah, I
Pilot.
think viscose would be the right viscoelastic which I use. There's nothing wrong with that because I use most of my case. I use the chondroitin sulfate doing Ruxis. It's not an issue at all. And I would have used dye. I would have used dye. If I'm worried about going it back at place viscoelastic, the viscode there and stained it, just few drops. Because I think the key is visualization. I would, because my eyes are not so trained to identify, unstained capsule. So I would err on the try to go with the dye itself, and I would have stained it. And second option, there's an opportunity when you first of all you are not able to see well. I would have washed off all the viscoelastic and
Yeah.
then again stained the capsule. The
That's,
second when
yeah.
you're the second time when you want to put the ring in back, when we're trying and you're not able to see the capsule edge, even that time few drops of stain will
Stain.
delineate the capsule. There was an opportunity where you could have still done it. And viscoat is a perfectly fine this thing because the chamber is maintained without pressurizing it, and you also have a barrier. There's a perfect choice for using in a subluxury cataract. That's absolutely fine with that. So there is a chance of going behind. In this case, the zonular dehiscence was not so much.
Not so much.
That really wouldn't be bothering me. And using a forceps to when the half of it is stuck out, forceps is the best device to negotiate it back again. Because if you just use two synskukes, you are never going to deal with it. And always use two forceps, which you did ultimately, one to hold and one to maneuver. And having these instruments handy is extremely critical to deal with the situation.
Yeah. So keeping it in the special instrument set.
Yeah, absolutely. It is really required.
Having a lot of residents into my OR, it's always like a routine to use trypan blue. And at one point, I was accidentally engaged the anterior capsule during the incision. So I had a niche into the anterior capsule, and when the trypan blue was injected, the trypan blue got inside the bag under the anterior capsule. I don't know if that's another way to stain, but that happened that time. Probably if we don't want to stain the anterior hyaloid, we can use a trypan blue, not a trypan blue, but a 3-amsilanone. And that will stain a little bit the anterior capsule and will have no issues to the anterior hyaloid, even if that is staining.
Okay, that's a good idea. Yeah, that's a good idea. Okay, Dr. Sunil, can you share your video?
Yeah, I just wanted to ask Neto one, since he was old school. Did you ever do the Rexus under air? Before,
Yeah.
when we didn't have Trypan Blue, we used to put in air and do it, and you can visualize quite well.
Yes.
Although you can't maintain the chamber, that's another story.
When I was beginning my career and finished residency, we did extracapsular, and many times we didn't have any OVD available. So we had to do cases under air, implant the IOL under air. And it's a very good skill to have, to learn to work under air, because you have many times you have a very good visualization, and the anterior chamber is maintained. So it's a good point you brought. It's another technique to see, and under air you could you can accompany. Sometimes you stretch the incision and lose the air bubble, but in this case, if you were using a micro forceps, you would be able to visualize to get some vision of the capsular bearings.
I think we younger surgeons have poorer vision nowadays. We have to see.
With the air, Dr. Sunil, I think the trick with the air would be to you do it just with the entry with the needle itself, never an open chamber.
Yes.
Just with the entry with the needle itself, because I saw Dr. Ravindra, MS Ravindra used to do like that. Yes. He just used to punches the floor of the tunnel and go. There is absolutely closed chamber, no way the air can escape. Then he used to do it. So that was his era. He used to do it like that. I have seen him do. That was the trick, I guess.
Well, nowadays we can
Dr.
use
Sunil, yeah, Dr.
when
Sunil.
we have the Phaco machine, the vitrectomy machine in the OR. The vitreoretinal surgeons have air on the machine, so you can connect that to the anterior chamber line and have continuous pressure under air. But that's a good idea. I never tried doing airexis under air so far, so that'll be next on my list.
Shall I go ahead, Sourabh?
Yeah. Waiting. Yeah.
This one, no? The second case is not as dramatic as the first. It is probably a common complication that happens. And this is a transconjunctival small incision cataract surgery. And it's a small eye. There is no fixation, proper fixation, and hence there was a globe operation when I was performing my incision. And I probably used a little extra force and see what has happened. Got a good incision, but it's very deep. Almost there is a uveal prolapse. There's just a thin sliver of tissue covering. You can hardly see it. So now the way to get around this is to hold on to that conjunctiva anteriorly and slowly dissect out a superficial plane. This has to be done very carefully. Use sharp instruments. Since it's a transconjunctival, your assistant has to keep irrigating that area for you to visualize. Do not do this blindly. And once you get the plane, do not come out. Just stick to that plane and keep dissecting in that plane. Make sure you get your side pockets as well. Since I don't have a bridal suture, I have to keep shifting my limbs forceps to maintain some semblance of fixation. Once I get the incision done, I put in my side port, enter with the keratome. I perform my capsular excis, open up the incision. To be very careful, every time watch where you're going in the incision. Don't go through the deeper part. I'm using the sandwich technique. I could not bring out the entire nucleus, but I could dial it out. I then go ahead, take out the cortex, put in my rigid IOL in, and I place a single suture there. This is one. If there is a small leak, it should take care of it, and next to control against the rule astigmatism. And on day one, vision is 612, there is a minimal wound edema, no wound leak, and a well-formed and a quiet AC and a happy patient. Thank you so much for watching.
Thank you, Dr. Sunil. I think this is, we have all gone through this somewhere, but you were lucky that the iris never came out. There was some tissue which was still hanging around there. It never came out.
It never came out.
Yeah.
And there was some tissue there. But if it does come out, of course, I don't have time to show other videos. If it does prolapse, you will have to suture that first before you do the superficial dissection. So I was lucky it didn't come out. So I could do my superficial dissection first. And I got away with just one suture at the end.
If there is the iris prolapse is very severe and you sutured it, and if you're not confident of creating a superficial plane just above the original incision, would you suggest shifting another quadrant and going ahead?
Yes, you can do another quadrant, or what I would suggest is suture up the wound and do a Phaco. Yeah. Go ahead and do a Phaco.
Yeah, obviously, if the surgeon is not...
That's the best option.
I think that that skill to have done SICS is very, very important. And you guys are experts on that. Slowly in Europe, this it's slowly disappearing, but it's very, very important, especially for the young surgeons, to understand that having a skill to have a very nice, well done tunnel can save you sometimes from a great deal of trouble. In Europe, they used to do extracapsular Phaco, not Phaco, but extracapsular cataract surgery by cutting the cornea for like 100 degrees and then placing sutures on the cornea, which is very traumatic for the eye and do a lot of astigmatism post-op. But having a nice tunnel formed, you can always end up with actually no sutures at all. If like Dr. Sunil did here, the tunnel after that, without having that complication of opening the sclera all the way down, you could end up with no sutures at that surgery. So it's very, very important, especially for the European surgeon, to get that skill and really understand and learn how to do a nice SICS with the pockets and everything, especially in the brown cataract or the zonular dehiscence, which is very, very extended. That can save you a lot of trouble. So thank you a lot for showing this case. It's very, very good for the young surgeons.
Dr. Neto.
Yeah, wonderful case, Sunil. Wish I have your skills making this tunnel. We marvel at the ease you do your incisions and tunnel. I would like to ask you if you think, is there much advantage doing the surgery, the transconjunctival approach, than on the other way, dissecting the conjunctiva and then making the tunnel?
Oh yes, there are a lot of advantages. One is it's you just make a small nick on the conjunctiva. So later on in the future, if you have to do any filtering procedure, it's probably, although there are no studies, but is probably you can manage. That is one thing. The next, you do not do scleral cautery. There is no cautery. So it is much more physiological. And there is no cautery, and there is no conjunctival dissection. So it's much physiological. It's very, very comfortable for the patient. Extremely comfortable. And if you see the post-op that I showed you when I turned down the eye, it just settles down. There is no suture. I don't even put a subconjunctival. Whereas if you do it with a peritomy, you would have to suture, or you had to cauterize the ends, or you have to give a subconjunctival. And if you look at them post-operatively, I've seen many of these cases. When you look, they're not very happy eyes. They do have a lot of irritation. Whereas this transconjunctival, absolutely no problem. But there is a learning curve, as you know. And when you land up with a complication, if you have a peritomy, see that deep incision, if I had a peritomy, it's much easier to do the superficial dissection. But with a peritomy, because it's actively bleeding, the only way to get around that is your assistant keeping on flushing the incision to clear it up, and then you can do further. So that's the off, but it has the other advantages.
Yeah. Do you think this approach is limited to smaller incisions or any size? Even if you have a very advanced cataract where you have to make a bigger incision, is it easy or okay to do this approach?
It's no problem. The size doesn't matter. For once, it doesn't matter in this situation. So you can do it for, in fact, I do it for very advanced cataracts, and the incision is big. Frequently, what I find a problem nowadays is we are always trying to compare SICS with Phaco, and people are trying to make it smaller and smaller and smaller. You have to understand, please take SICS for the advantages that it has. You get a sutureless surgery, you get peaceful surgery. You will not get, all the complications that you can get in a Phaco. It's once you learn it, and it can. So you have to take it. If you keep concentrating on the astigmatism part of it, the length of the incision, and you try to do intraocular maneuvers where you're breaking it within, then those are the learning curve becomes that much more tougher. And I think SICS is a beautiful surgery, and already Adrian has, as he rightly said, now in Europe, they want to learn this. This can bail you out in so many situations. And in fact, when I go abroad, all the people from abroad who come there, they don't want to learn Phaco from me. They only want to learn SICS.
It's very, very important. Yes, and you have this wonder if that really will leave an astigmatism or not after you do 6-7 millimeters of dissection and all that. I did it. I couldn't believe it that there is no astigmatism.
There is no astigmatism.
So at first I was suspicious. Really, how can a 7 millimeters opening on sclera will leave you with no astigmatism? But if you do it right, like there are a couple of videos on YouTube that really teach you step by step how far to be from the limbus on each side and in the center and all that. And like Dr. Sunil said, if you do that conjunctiva, pull it towards the limbus and then make the incision towards the conjunctiva, then you end up with a beautiful surgery without having any sutures to place. And it's like I couldn't believe it. I was not. I really blew me off the results and the fact that you have really no astigmatism after this surgery, if he is done right, of course.
Okay. So I will play the last video by Dr. Adrian, and I will share that video. Actually, the only problem with SICS is that for Phaco there is a Phaco machine, but for SICS there is no SICS machine. So I think that's the big
marketing is a problem.
You gotta be the machine.
This is a procedure
This
done
is Dr.
with
Adrian's case.
Constellation Phaco machine, vitrectomy and Phaco machine. And I usually have the parameters on like 650 vacuum here, which is pretty high, especially proved to be high in this case when instead of taking out the cortex and epinucleus at the end of the phacoemulsification, I choose to do it earlier, and that proved to be not such a great move. And having these high parameters, I usually keep the chopper underneath the Phaco probe, which in this case I didn't do it. So one thing, and you see here the vitreous and the scintillance that is very disturbed when the PC rent occur. It's very important not to take out the Phaco probe when these incidents happened, and when we inject the viscoelastic, it's good to just inject it in a sweeping manner, so the viscoelastic is pushing any type of strands of vitreous that might come into the bag and anterior chamber to be pushed back by the viscoelastic, and it's good to go with the viscoelastic needle underneath the Phaco probe in a sweeping manner, so we disengage any strands of vitreous that might got cut into the Phaco tip. I have the switch on and off at the pedal, switch pedal, and I can activate and deactivate the cutting mode on this vitro cutter. So I can use it here without cutting mode, just aspiration as an IA probe, and take out the cortex remnants from the bag into the middle safe zone, and then activate the cutting mode to just activate and cut the cortex in a quick manner. That will fasten your surgery very much. I supplemented the subconjunctival anesthesia at the trocar level, and injecting the IOL on top of the iris here first, and then gently maneuver it inside the bag. First, the leading haptic, you can see that is going nicely underneath the capsular axis rim, and then slowly, gently maneuver the IOL, the optic inside the bag, and by twisting a little bit the trailing haptic that can be placed also inside the bag and nicely center. So we can see that even in these challenging cases when a complication of PCURent occur, we can still manage the case nicely and have the IOL inside the bag at the end of the surgery, and everything can back to normal. Thank you for your attention. I hope this will help in your practice also.
Okay. Yeah, Deepak.
First mistake here was that having trocars placed into the eye at the beginning of the surgery before phaco emulsification will give you a soft eye. Having a soft eye from the start will have your posterior capsule very much fluctuating and very easy to get cut by the phaco port. And then, of course, I took out a lot of the cortex and the epinucleus before the chunk of the nucleus, so that will give me some backup material in between the nucleus and the posterior capsule, which I took out. That was the second mistake. And the third mistake, I didn't place the chopper in between the Phaco probe and between the nucleus and the posterior capsule. That will have prevented the posterior capsule coming forward. And of course, having high vacuum parameters in this fluctuating posterior capsule will invite the posterior capsule into the Phaco probe.
Deepak, unmute yourself.
Thank you, Adrian, for the case. There are reports which have been reported in the past that the incidence of PCR is slightly higher in eyes with asteroid because one of the argument is that the PC is slightly thinner. So there are reports which suggest that the incidence of PCR is slightly more in cases with asteroid. But I like your demonstration of using the Phaco, the vitrector, to do the vitreous cutting and as well as to aspirate the cortex, which you did it very well. And again, the AC maintainer which you used came in very handy. You know, you didn't have to use two hands. It was already fixed there and you could do it well. So that was nice.
Yeah, I think very good demonstration. I think as he rightly said, putting the pores before doing phaco is like making the eye with very low scleral rigidity. So it's like how we get in very highly myopic eyes. So the trampoline kind of that the same thing that he was experiencing while doing phaco. And I think afterwards he managed it really well. Okay, so that's the end of our cases. So any additional things that panelists would like to add, starting with Dr. Neto, before we end the session?
Well, I think we saw many situations where we can learn, let's say like that. I think we have to keep in mind that mistakes can occur all the time. So when you are doing not only difficult cases or challenging cases, routine cases, we have to keep all these occurrences that can happen in mind to avoid them. And sometimes I think one of the most important things when dealing with complications is the early recognition of that. You must stop what you're doing and think fast if things begin in a different way, or in a way that you say that's there is something happening. we have to recognize the error or the complications at an early stage so as not to progress. But I think the message that we are passing here is that we can learn from each other. I think the videos, YouTube or other platforms are a wonderful way to learn from other surgeons. And we really learn from watching videos. I usually, when I'm exchanging experiencing people, and I say, I watched your video 5 or 10 times, they say, why so many times? Because it is necessary. I usually do that. I often watch a video many times, and each time you can get more detail from the video. It's amazing how much you miss on the first time you see, and you think a little more and you watch it again. So I think the message I would pass here, especially for the young surgeons, pay attention to other videos. And when you have experience in some cases, you come back to videos that you already watched, and you will learn more from them. And that's something that happens to me, and I'm sure it will be others' experience too.
That's I think wonderful statement that to watch your videos. I think that's the way to learn. Dr. Sunil.
Yeah, just to take on the same thing. It's I would just not only watch others' videos, watch your own videos and watch it carefully, watch it unedited, watch it. And when you're on the table, sometimes we get a complication and we think, oh, we can manage like this. This has happened. Don't ever fool yourself on the table. Never get into that mindset. Always remember things are going wrong. And if something is, I always believe surgery is like mathematics. It goes step by step by step by step. If something is not happening, something is wrong. If you're not able to rotate the nucleus, something is wrong. If the chamber is not forming, something is wrong. Please don't think, oh, this is just one-off situation. Doesn't happen like that. So, and the more you watch videos, I'm sure in Neto's time, our time, we didn't have this opportunity. I remember when I was doing my residency, there was just one observation tube and 12 residents. Everybody used to take turns to look at the professor operating. We didn't get much. And I was the most junior. The only thing I used to watch was how he was sitting and how he was using his hands from outside. I never got the observation tube. And I think, that everything is important. You observe, just fine. And the most important thing, excellent topic, Saurabh and Deepak. I mean, you've done it again. These are the topics that are more important. And, bringing out mistakes. These are not mistakes. This can happen in anybody's hands. This is a learning experience. And these are the best lessons that we can learn. Our complications or when things go wrong. That's when we learn. Thank you so much. Really, I have to appreciate both your efforts. You just don't stop trying to teach. Fantastic. Good job.
Thank you, Dr. Sunil. Dr. Adrian.
Yeah, thanks a lot for the opportunity, and I learned a lot today. It's very important to make the young surgeons understand that everything is important. No little details have to be missed. And like Dr. Sunil said, even watching the professor, the main surgeons, how he's moving his hands, the angle of the instruments, how he's touching the pedal, how deep the pedal is going, and when he's getting released, all these kind of details that seems to be unimportant into a real situation will make a lot of difference if you know how to use the instruments right and how far, how long to push the pedal and so forth and so on. And having all the complications run through, have even or your own complication or seeing other people how to handle the complication will make a lot of difference when you run into that kind of situation, and having the mindset of remember what other people did in that situation, what you did to fix the situation, and how Dr. Sunil said is very, very important. If something gets wrong, look for the reason why is making that unwillingly, or how that step is not going the right way. That means it's a problem or a complication there, or something is wrong with that kind of particular step. So try to understand what is wrong with that step and make it the right way, and don't jump to that the next step into the surgery. And having all the tools in your bag to know how to handle an SICS if it's necessary will make a tremendous difference in some patients' eyes. So always keep on learning is very, very important all throughout the one surgeon's career, regardless of how experienced he is. He always have to improve his techniques, and I'm sure everybody agrees that regardless how experienced we are, we always have some little trick to learn from somebody else.
Dr. Deepak. Thank you, Dr. Adrian.
I think on behalf of phacotraining.org.in, I would like to thank Sunil, Neto, and Dr. Adrian for sparing your valuable time and also sharing your views and your cases. We learned a lot from you because our motto is to learn and to teach. That is the motto we want to live. And thank you for being a part of this, our passion or for a goal. And we really appreciate, because sparing some time to prepare the videos, hunt for videos, and taking time out to participate in our event itself is a great honor for us, and we're privileged to have you. Thank you so much for your time. Sourabh.
Thank you so much, all. I think it's a great honor to have you all, and I'm really pleased that next time we'll have more horrific films, more horrors from our OTs. I think we'll look for them now with intent, because we have to have another season of this big mistake. And I think it's good thing to look for those videos, because many times we only remember the good things we have done in OT, and we forget our mistakes we have done, in last OT or previous OTs. So I think we'll keep those videos with us now to present in our next season. So I think let's stay tuned for the next season also. And thank you so much for sharing your mistakes with us all and how you treated them. And I think whenever I live stream my surgeries, the comments that I look for are the hate comments, where the audience is saying that this was a wrong maneuver, you could have easily had some complication. I think these are the points which actually make me more knowledgeable, because many small points I miss when I'm doing actually surgery, and these are the comments that makes us better. So thank you so much all, and we'll end this session now. Thank you so much, Dr. Adrian and Dr. Neto and Dr. Sunil. And we'd love to have you again back for the next few seasons. So do, now work on your mistake videos so we can have many more.
I have plenty. Don't worry.
That's great. Thank you so much. Thank you so much, all the attendees on the Zoom as well as on the YouTube.
It was
Thank
wonderful to be here with you.
you. Bye bye. Bye bye. Stay safe, all of you. Take care. We'll be in touch.
Sure.
I will end the session now.